É muito comum as pessoas reclamarem de ver nuvens, alguns filamentos fazendo sombra, que o objetivo é ver melhor, e aí isso acentua muito. E nós já tivemos casos que tivemos de intervir, e agora a gente já prevendo, quando as pessoas já têm queixas, a gente já faz uma cirurgia junto com a cirurgia da catarata. Nós chamamos de vitrectomia transcapsular, pela via anterior, e limpamos essas manchas, as pessoas ficam muito satisfeitas.
The owners of the visual disability caused by floaters or symptomatic vitreous opacity has increased, especially for the diagnosis and evidence-based treatment, mainly using a small gouge vitrectomy. A minimally invasive transcapsular anterior vitrectomy technique is an alternative to the technique described in the evidence-based treatment. This technique can be applied in cases such as high-loss symptomatic vitreous opacities, in case of postoperative visual succession of patients undergoing trifocal lens implantation. All patients need to undergo a detailed retinal exam before. After phacoemulsification and intraocular lens implantation in situ, an anterior chamber maintainer is attached to the paracentesis, or the phacoemulsifier silicone tip is positioned over the IOL for continuous irrigation under low positive pressure. The vitrectomy probe is introduced by the paracentesis in a scale movement, positioned under the IOL body. The tip of the vitrectomy probe should be turned, so its opening is positioned towards the posterior capsule. The probe's correct position is near its entrance and under the IOL body. In performing capsulotomy, the possibility of rupture of the posterior capsule happens due to even its fragility, or to elevated ocular pressure, or to the position of the vitrectomy probe. When the ocular pressure is high, the posterior capsule is under tension and can be turned by the cut of the vitrectomy probe itself. The capsulotomy should not be performed in the center, but in the periphery, near the tip of the vitrectomy probe. At a very low rate of cut and aspiration of the vitrectomy probe, there is no lever at the edge of the capsule, avoiding unnatural breaks. A successful capsulotomy is the size of more or less 3 times the diameter of the tip of the vitrectomy probe. In capsulotomy, it is necessary to deepen the tip of vitrectomy probe to vitrectomize vitreous opacities. In doing so, the velocity of the vitrectomy must be high to avoid vitreous traction. The aspiration should not be too high, but just enough to remove the opacity. The aspiration needs to be proportional to irrigation to keep the structures stable. The vitrectomy must be performed only in the center of the eye, focus only in the opacity that disrupts the visual axis, since a peripheral opacity may come to the center. When removing the vitrectomy probe, make sure to remove the vitreous near the posterior capsulotomy to avoid the traction of the retina. The lens body to block the small posterior capsule.